Hello everybody, welcome again. This is Richard Rosedale. I'm in London, Ontario, Canada, and chatting to my friend Georg, who's in Freiburg in Germany.
Hi Richard.
So it's pretty much a regular topic on social media, Georg, seems to be about posture, especially with low back pain patients, spinal patients, giving patients posture, especially associated with MDT, the McKenzie system. The impression is that we give posture correction to everybody, regardless. So I wonder what your thoughts were on that.
Yeah, funny enough, you're mentioning this today because I just read an editorial of Josh Sadro from Australia, where he was referring to an older study he published some years ago, and actually there he's emphasizing the fact that I think about 70 or 68 or 70% of clinicians, or in cases, clinicians give advice on posture for low back pain patients. And he's actually picking on this. So, and not McKenzie folks, but in general clinicians.
Right, so it's not just us that are getting blamed.
It's not just us, no. But just talk, maybe we come back to this later. Let's talk about us, the McKenzie folks first. So I think we should not forget the historical background here. So when in the 60s, when Mac worked on this system, at that time it was basically modalities which were used for low back pain, and it was medication, it was bed rest, it was even surgery. And he was the first one who detected there's something else. There might be possibilities where patients can have an influence on their pain. So which are, and of course, movements, directional specific movements were one thing, and the other thing he found was that some patients, they just reacted on posture change. So that, and posture change was one of the strategies he found where patients can actually have an influence on their pain and not rely on other things and other stuff. So, and we should not forget where this is all coming from. So, and posture at that time was just, oh, cool, I can do anything something by myself, and don't have to see a surgeon or a pharmacologist.
Yeah, so is there a problem with that? I mean, if you know, you see a patient comes in and you go through the assessment and they have current back pain, perhaps leg pain as well, and you change their position from, say, a slouch position to an erect position, and immediately they get a response in terms of their symptoms, perhaps their leg pain feels better, goes away. Is that a problem? And is there anyone out there that wouldn't give that to the patient as a means that they can control the symptoms and control the pain?
I think it's hard to argue with that. It's hard to argue with that. I think one of the arguments which is brought up is, okay, it might be just simply pain modulation. You might simply just doing something with pain modulating and not really changing anything.
But is that a problem? If that's within the patient's control to be able to change something simply that has an immediate effect on their symptoms, regardless of the mechanism, what's the problem there? You know, great, the patient doesn't care, I think. They can do that anytime. They don't need you to put your hands on them to do it. They don't need any sophisticated equipment. They just need to change their position in order to have some control over their symptoms. And I think...
Yeah, I think that's a good point. And in my daily clinic, I see that it's a good opportunity to get the patient on board. So you can show him, okay, there is some control over your pain. Of course, not overemphasizing it. There is some control. It makes also adherence easier. If you change anything, something with posture change, and the patient gets immediate relief. Even if it's not the long-term solution maybe, but it is immediately a way to get the patient on board.
So getting away from the prescriptive thing of saying, okay, you know, this is what you need to do. You need to sit upright, regularly, and this will, this is your problem, and this is what you need to do to kind of to solve it. And I think that alliance of talking to the patient, if you can demonstrate that, and the symptoms change, asking the patient, so what do you think about that? Do you think this is something that you would be willing to do in order to control your symptoms?
Sure, and then it's important, I think, also to communicate in the right way. So if a patient is asking you, okay, so posture is my problem, I might say, or I always say, oh, no, it might be part of the solution, actually, changing the posture. It might be one part of the solution. So again, mind our words with that.
Yeah, that's right. So I think we do have to be very careful how we couch that, because we don't want the patient going away thinking that that is their problem, and not only do they need to change it, but it may be a really bad thing for them to then resume their previous posture, and it may be damaging for them. They may be afraid in a way to adopt the posture that's associated with the pain, not just when the pain's here, but into the future. So we have to be very careful how we phrase that to make sure this is a temporary solution for you that obviously has an impact on your pain. So I think we can use this, you can use this strategy if you think you'll be able to do that.
Yeah, and what about, does posture cause back pain or neck pain?
Yeah, I think we have some pretty good evidence now to suggest that that's not the case. So I think we have to be careful not when we're talking to the patient to make sure what we're saying is based on evidence too. But I think there is some evidence to say it's associated once somebody has back pain, then sitting and the way to sitting can be associated with getting more back pain. So to control that, if the patient can control that and control one of the aggravating factors, then again I think that's a no-brainer.
Yes, and so I think I've heard a few times that we should think about sitting might be just one activity they just do very often during the day, and that is why they are so aware of that sitting aggravates the pain. But sitting might not be the main issue. It might be just the one thing they do very often during the day.
Yeah, that's right. Again, I don't think it's necessary to make it into sort of such a massive big issue. But if we can make it part of the solution for the patient they can control, then again, I think that's, regardless of the evidence in terms of causation, I think that's a logical and sort of rational approach to take with our patients. Now, so the other thing about posture is from our recent study where we looked at the predictors in terms of, for an extremity problem, which problems need to be treated from the spine and which problems need to be treated from the extremity, or indicating that. And we found that posture change, if it has an effect on that extremity symptoms, was one of the strongest indicators we had.
So posture change, using posture change to differentiate, for differentiation, might be helpful.
That's right. So as part of the assessment, as a nice simple tool you can use to help with that differentiation process, and it increased the likelihood by 4 times that the problem was coming.
It's quite a lot.
So keeping the extremity still and then moving the spine, the neck, the low back, and see from that changed our baseline.
And I think the important thing is we moved away from talking about good posture and bad posture. We just look, does it make a change? Does it change anything?
Yeah, that's right. And actually, that's even apparent on the change with our assessment forms.
Sure.
We moved away from the correct, the good and the bad, and we moved towards just about posture change. And I think that's the recognition that it's not necessarily everybody sitting upright where that positive effect is going to happen. Okay, and that's why we explore it. Some people, when they're in an erect position, that exacerbates their pain. And so in a slouch position, it eases the pain. So we use that information in order to direct the patient appropriately in terms of the influence of the posture on the symptoms, and whether it can be used as part of their strategy, and what type of posture.
So what about posture change if the change of posture in this session, let's say during the evaluation, does not make any change? Would you go ahead and suggest posture change anyway, just because you think, oh, this posture looks kind of suspicious to me?
Yeah, so I think two things there. One, of course, the history is an essential part of our assessment. It's not just what we find in examination. So if the patient's coming in telling you that when they're sitting on the couch for long periods of time, that definitely brings on their leg pain and numbness, and when they're sitting in a dining room chair, upright, that is definitely more comfortable, they've got more tolerance. And again, I think you can use that information in terms of your education, and not to, I think, would almost be sort of neglecting that, if you like, and that can be simple. So in that circumstance, I would. If posture seems to make no difference in the history to the patient, and you don't find it makes any difference in the exam, then I think it's kind of, you have to then decide whether really you justify giving posture as part of the intervention or not. But I still think there can be a reason to do that in some circumstances.
Yeah, I think as long as we communicate it to the patient, and the patient understands this is, again, kind of an experiment he does with his back. Does this make a change? Does it give me the opportunity? Does it make it possible for me to control my pain or change my pain? So as long as we communicate this, it might be helpful, so beneficial to work with posture.
Yeah, I think so. To chat with the patient about that, and for them to go away and see what the impact is of their posture, and then if it does have an impact, then they go about changing that, I think is a reasonable rationale as well, for sure.
Oh, that was a nice chat today, Richard.
Yeah, nice speaking to you, Georg. Hope people found that interesting.
Yeah. So go ahead and use posture with your patients in a reasonable way. Would be great. And so, bye, Richard. Have a great day.
Bye, Georg. Have a great day. Bye, everybody. Thank you for listening.
Bye, everybody.